ACLS Overview, Advanced Cardiac Life Support, what every healthcare provider needs to know. Magna Johnson Buckner, MSNRN, Certified Senior Care Advisor, and I'm also certified in teaching ACLS, PALS, and CPR. Please sign up at comficarecpr.com for your ACLS, BLS, and PALS. Now let's take a dive into ACLS Overview. What is ACLS? Advanced Cardiac Life Support. AHA developed a system of algorithms for life-threatening emergencies built on basic life support foundation. It's required for all RNs, MDs, PAs, paramedics, respiratory therapists, and more. So first, we want to recognize life-threatening rhythms and conditions, and next we want to respond, apply correct algorithm immediately, and restore spontaneous circulation. So there are 4 core ACLS algorithms. The first one is cardiac arrest algorithm, bradycardic algorithm, tachycardic algorithm, post-cardiac arrest care. Every ACLS scenario falls into one of these 4 pathways. Adult cardiac arrest algorithm, shockable. So this algorithm have 2 sides. One side where you can shock and the other side that is non-shockable. So the shockable side is the ventricular fibrillation and pulseless VTAC. Defibrillate immediately. Resume CPR times 2 minutes. Get epinephrine 1 mg IVIO every 3 to 5 minutes. Amiodarone 300 mg or lidocaine 1 to 1.5 mg per kg IV after the 3rd shock, and check rhythm every 2 minutes. For the non-shockable side of the rhythm, it's a PEA and an asystole. Your goal is for high-quality CPR immediately. Epinephrine 1 mg IVIO every 3 to 5 minutes ASAP. Treat reversible causes, the H's and T's. No defibrillation required, and advanced airway and capnography. So you want to push hard and fast, 2 inches, 100 to 120 per minute, full chest recoil, minimize interruptions, and check rhythm every 2 minutes. Reversible H's and T's. So you have 5 H's and 5 T's. You need to know these. Hypovolemia, you're going to give fluids. Hypoxia, oxygenate and ventilate. Hydrogen ions acidosis, you're going to give sodium bicarb and ventilate. Hypo and hyperkalemia, you are going to do calcium, bicarb, insulin, and glucose. And hypothermia, active rewarming. Tension pneumothorax, these are the T's. You're going to do needle decompression. Tamponade cardiac, you're going to do pericardia centesis. Toxins, antidotes and supported care. Thrombosis coronary, cardiac lab and cath lab and thrombolytics. Thrombosis pulmonary, thrombolytics and surgical. Shockable rhythm, ventricular fibrillation and pulseless VTAC. Ventricular fibrillation is a chaotic, irregular electrical activity, no organized waveform, no recognizable P waves, QRS, or T waves. Rhythm looks like a jagged, wavy, disorganized line. Ventricular rate is 300 to 500 plus chaotic deflections per minute. No cardiac output, patient is pulseless and unresponsive. Treatment, defibrillate immediately. CPR, 2 minutes and repeat. Pulseless ventricular tachycardia. So the rate for the pulseless ventricular tachycardia is greater than a rate of 100 beats per minute. Regular or slightly irregular. No discernible P waves, AV dissociation. Monophoric uniform QRS shape. No pulse despite organized appearance of the rhythm on the monitor. Treatment is to defibrillate. CPR 2 minutes. Epinephrine, amiodarone, and lidocaine. Non-shockable rhythms, these are the PEA and asystole. Pulseless electrical PEA, organized electrical activity on the monitor, but there is no pulse. Any rhythm, sinus junctional idioventricular without cardiac output. Most common shockable arrest rhythm in adults. Always, what are the underlying reversible causes, the H's and T's? Treatment, CPR immediately. Epinephrine, 1 every 3 to 5 minutes, treat your H's and T's. Asystole, flatline, absence of any electrical or mechanical cardiac activity. Flat or nearly flatline on EKG confirmed in 2 leads. Poorest prognosis of all cardiac arrest rhythms. Do not defibrillate. Shocking asystole is never indicated. CPR immediately, epinephrine 1 milligram every 3 to 5 minutes, and confirm in 2 leads. High quality CPR, the foundation of ACLS. The rate is 100 to 120 per minute. The depth is 2 inches. Recoil is full chest recoil and less than 10-second pause. Minimize interruptions, switch compressors every 2 minutes, and no excessive ventilations. Bradycardic algorithm, heart rate less than 60 beats per minute. Identify heart rate less than 60 beats per minute plus symptoms. Signs of instability, such as hypotension, altered mental status, ischemia, or acute CHF. Stable, observe, do a 12 lead, identify the cause. Unstable, atropine 1 milligram IV, repeat, Q 3 to 5 minutes, max dose of 3. If atropine fails, you can do transcutaneous pacing or dopamine 2 to 20 mics per kg per minute or epinephrine 2 to 10 mics per minute. So the key is atropine is the first line for symptomatic bradycardia. PACE does not wait for atropine to fail in high degree blocks. Tachycardia algorithm, that's heart rate greater than 150 beats per minute. So you have two kinds. You have this unstable and the stable. For the unstable, signs of hypertension, altered level of consciousness, ischemia, chest pain, acute heart failure, synchronized quarter-version. Energy settings, narrow regular 50 to 100 joules, narrow irregular AFib 120 to 200 joules, wide regular VTAC 100 joules, wide irregular defibrillate unsynchronized. So, there's stable, tachycardia, now and regular SVT, vagal maneuvers, adenosine 6 milligram rapid IV, 12 milligrams if the 6 milligram doesn't work, now plus irregular AFib, diltiazem or metoprolol rate control, amiodarone rhythm control, wide plus irregular VTAC, amiodarone 150 IV over 10 minutes or propanamide and sotalol can also be used. Wide irregular Torsades, 2 milligrams IV over 15 minutes, and unsync shock if pulseless. Key, unstable, cardiovert first, no delays. Adenosine only for narrow irregular SBT. Sync cardioversion, not defibrillate except VF. ACLS medication cheat sheet. Epinephrine is a vasopressor. Indications for VF, pulseless VTAC, PEA, asystole. 1 milligram IVIO Q 3 to 5 minutes, push fast, follow with 20 mL flush. Atropine is an anticholinergic, symptomatic bradycardia, 1 milligram IV Q 3 to 5 minutes, maximum dose of 3 milligrams, not for most with 2 third-degree heart block. Adenosine, antiarrhythmic, narrow regular SVT, first dose 6 milligram rapid IV, and you may go to 12 if it doesn't work. Give close to the heart, flush fast. Amiodarone is an antiarrhythmic, using VF pulseless VTAC after third shock, unstable VTAC, 300 milligram IV bolus, 150 milligrams IV infusion, monitor for hypotension and bradycardia. Lidocaine also is an antiarrhythmic, VF pulseless VT, alternate to amiodarone, 1 to 1.5 milligrams per kg IV, can repeat 0.5 to 0.75 milligrams per kg, Q 5 to 10 minutes. Magnesium sulfate is an electrolyte used in depointes or hypomagnesemia, 2 grams IV over 15 minutes, slow push, monitor BP. Dopamine is a vasopressor indicated for bradycardia, second line hypotension, 2 to 20 mics per kg per minute infusion, titrate to effect, watch for tachyarrhythmia. Now, post-cardiac arrest care after ROS. Now, the goals of the return of spontaneous circulation. After that, you want to focus on oxygenation, maintaining SATs 92 to 98%, avoiding hypoxemia, and PET CO2, maintaining a PET CO2 of 35 to 40 millimeters mercury. For blood pressure, you want to maintain a systolic blood pressure greater than or equal to 90 mmHg, MAP of greater than or equal to 65 millimeters mercury, and use IV fluids and vasopressors to maintain this. Target temperature management, we are going to run that 2 to 37.5 degrees centigrade for 36 hours. You want to prevent fevers greater than 37.7 degrees centigrade and avoid an active cooling device. Now, prelude ECG. Check for STEMI immediately. Cath lab if STEMI or high suspicion. Early reperfusion has a better outcome. Neuro assessment, their pupils, assess them, 4-score, CT of the head. If unclear, neuro prognostication greater than 72 hours. And of course, we're going to maintain her glucose 140 to 180 millimeters per DL and avoid hyperglycemia and do frequent monitoring. Have ACLA exam tips. Pass with confidence. We want to check the pulse, no less than 10 seconds. If in doubt, start CPR. After defib, start CPR. So the epinephrine is given as soon as the IV or IO access is available in non-shockable, third shock in shockable rhythm. Now, atropine does not work in Mosby's 2 or third-degree heart block, so go straight to pacing. Adenosine, first dose is 6 milligram rapid push with fast flush. You want a big vein like in the antecubital fossa or a larger vein. Torsades, magnesium sulfate 2 grams IV, wide irregular plus log QT, think torsades. Unstable, cardivert first. Don't waste time on meds if patient is crashing. Post, Ross, target temperature management 32 to 37.5 for 36 hours and avoid fever. H's and T's must know them all. Hypovolemia is number 1 cause of PEA. Organelle gas is not normal breathing. Treat as coronary arrest if unresponsive and there is no normal breathing. Why get ACLS certified with CompuCare CPR? Align is aligned with AHA curriculum and we are current with the 2025 guidelines, taught by myself and required for RNs, MDs, PAs, and EMTs. We have flexible scheduling and we also teach PALS and CPR. We have small class size personalized instructions. It's not a lecture hall. So I just want to shout out again, we welcome you to sign up at CompuCareCPR.com for our classes. Our phone number is 240-676-4239. So go ahead and register for your class today.